Tamasoma Jyotirgamaya. Let the light of knowledge remove the darkness of ignorance. I'm Dr. Rujuda Machwe, Secretary, Pune Ophthalmological Society, and I welcome you all, dear friends, colleagues, seniors, for the third POS clinical meeting. Welcome you all on this Sunday morning. Like everybody knows, we had a very successful first of its kind hybrid conference, which was the first hybrid conference in Maharashtra, POS Spectrum 2021. And everybody really enjoyed it being hybrid. So they had the physical fun of meeting everybody, then had a great scientific extravaganza as well as fun and frolic. But now we are back again on the virtual mode, thanks to Omicron. But yes, that's okay, isn't it? Welcome you all for the third POS clinical meeting, and we'll be having interesting cases presented by PGs from different institutes. So without doing further ado, may I request President Dr. Sanjay Tekawade sir to take over. Over to you, sir.
Good morning. Good morning, everyone. I once again welcome you all after, as Vita mentioned, a very good discussions in our annual conference that we had last month. Within a month, we have now come up with a clinical meeting, but as due to the COVID restriction, this will be online meeting. I, on behalf of Team POS and my co-chairman, Dr. Sanjay Shah, welcome you all. I specifically thank Colonel Vichare and Dr. Madam Meenakshi Bhagali, who consented to be the judges for today, and all the seniors who have joined today. I wish all the participants all the very best. May the best of you come out today. And I, at this moment, also request those who are not members of POS to become member of Pune Ophthalmological Society, so that you are eligible for all the awards and the benefits of these presentations. Thank you. Now I hand over to Nitika, who will be moderating this session.
Hello, everyone. I first of all request all of the attendees to please switch off their video and please mute themselves during the session. And we have very tight schedule today, so I request all the attendees, all the participants to kindly stick to the time given to them. Now I'm just starting to share my screen. Okay, it's not sharing. Okay.
Yeah, it's there.
Let's see, Nitika.
First of all, let me explain the rules for the case presentation. The time limit for the case presentation is 6 minutes for each participant. 2 minutes for the judges. The judges question answer session, 2 minutes are allotted. The awards will be bestowed during the POS AGM for only the POS life members. There are awards for maximum number of case presentations, most interesting case, and best case. Let me introduce to the chairpersons. Dr. Sanjay Tekawade sir, our own POS president. He is a graduate and postgraduate from BJ Medical College, and he has done his residency from ophthalmology, Taparia Institute of Ophthalmology from Bombay Hospitals, and he's practicing for last 27 years in phaco and refractive surgery. Dr. Sanjay Shah sir, he's in private practice since 32 years. He's HOD and PG teacher at KM Hospital, Pune, and he's past president of Pune Ophthalmological Society and was the conference coordinator of the first successful hybrid conference, POS Spectrum 2021. Now, among the judges, Dr. Meenakshi Bhagali ma'am, she is a well-known ophthalmologist and she's the director of Medilaser and Bhagali Clinic and Nursing Home. She is graduated from GS Medical College. She is a gold medalist from the college, and now she is practicing comprehensive ophthalmology since past 39 years. Our second judge is Colonel Nitin Vichare sir. He's practicing at Command Hospital and he's trained in oculoplasty, and his topic of interest are socket surgery and ptosis surgery. Okay. Now, let's start with the first participant, Dr. Prachi Nalinde. She's from BJ Medical College and her topic is hemangioma. Over to you, Dr. Prachi. Please start sharing your screen and please unmute yourself and start your video.
Yes, ma'am. Good morning to everyone. I am Dr. Prachi Nalinde, pursuing second year residency from BJMC and Saswan Hospital, Pune. My case is informant being mother, a 6-year-old female child complains of swelling over the left eye upper lid since 3 months. She was apparently asymptomatic 3 months back when she developed a swelling over the left eye upper lid, which was painless, progressively increasing in size with redness. She has a history of intralesional steroid injection 3 months back, followed by a decrease in the size of lesion and again increase in size after a month. The child was prescribed eye drop timolol and tablet propranolol, which was not used. There is no history of any pulsatile mass, no history of any ocular trauma. Birth history was normal. There was no, she was not allergic to any of the known medications. Personal history, family history, and general examination was within normal limits. Now let's come to ocular examination. Head posture is normal. Ocular posture of right eye is normal. Left eye shows complete ptosis. Extraocular movements of the right eye were full, free, painless in all cases, whereas of left eye cannot be assessed. Visual acuity of right eye, the child follows light, whereas of left eye cannot be assessed. This is a picture of the child where the left eye shows the lead mass. Now the lead of right eye is normal, whereas of left eye shows a lead mass measuring 6 by 5 by 2 centimeter in size, firm in consistency, non-tender, which blanches on pressure. Increase in size is noticed while crying. It is non-pulsatile. There is reddish discoloration of skin at the lead border with the loss of eyelashes in that part. The rest of the anterior segment and posterior segment examination of both eyes was within normal limits. The intraocular pressure of right eye was 14 mm of Hg, whereas of left eye cannot be assessed. The fundus examination of right eye is normal, whereas of left eye cannot be assessed. So investigations, blood reports were seen which were within normal limits. Local USG was done, which showed a soft tissue mass of left eye upper lid. The CT orbit was also done, which showed the same finding without any intraorbital extension. The patient was started on topical application of timolol 0.5% 2 times a day and tablet propranolol 2.5 mg 3 times a day according to pediatric dosage. And the follow-up was done on OPD basis after 2 weeks, and the reduction in size was observed. This is the post-treatment photograph after topical application of timolol and tablet propranolol. Seeing the clinical history and the picture, the clear-cut diagnosis is capillary hemangioma. What is capillary hemangioma? It is a most common benign vascular tumor of infancy. The male is to female ratio is 3:1. The incidence of infantile hemangioma is 5%, of which 30% present at birth. The natural course is such that there is a rapid growth by 3 to 6 months and a slower phase of resolution where 30% resolved by 3 years and 80% resolved by 7 years. The presentation is a unilateral raised lesion which blanches on pressure, increase in size on crying, which leads to proptosis and ptosis. There is also hemangiomatous involvement of monoaxial and palpebral conjunctiva. Investigations like CT and MRI can be done to rule out the orbital involvement. Now treatment. Basically the tumor resolves by 7 to 8 years, but in 50% of the cases, amblyopia can be seen due to induced astigmatism, anisometropia, and strabismus. In these cases, we use beta blockers. It can be a topical application of eye drop timolol, or we can use it orally, that is tablet propranolol. Steroids can also be used, that is we use intralesional injection of triamcinolone acetonide and betamethasone. Also topical application of clobetasol propionate cream can be done. Systemic steroids can also be used like tablet prednisolone, but there are systemic side effects of the systemic steroids. Newer advances are interferon alpha-2 and vincristine can also be used in steroid-resistant site-threatening lesions. The last resort is surgery, where a local resection can be done with a cutting cautery and CO2 laser. Here my differential diagnosis can be lymphangioma and nevus inflammus. Lymphangioma is basically present from birth and it continues till adulthood. And in case of nevus inflammus, that is a port wine stain, blanching is seen on
Prachi,
pressure.
last 1 minute remain. Kindly conclude.
Okay, thank you.
Judges, questions for Dr. Prachi?
Good case presentation, Dr. Vichare here. I just wanted to ask, even after giving topical beta blockers and the previous history of injection transluminal intralesional, the photo you showed after management still had the complete ptosis. So what was the refraction done and what was the management option given to patient to avoid amblyopia?
Sir, we can do patching of the other eye, that is right eye, for 4 hours a day. Patching can be done.
But the patient is not able to open the eye. How are you going to see that the visual axis is opened up or visual axis is clear?
Sir, ideally we have to wait for 4 months when we use a medical treatment, so we can wait further whether the size is reduced.
Okay. Was any option of temporary sling was given to the patient?
What, sir?
Temporary sling.
No, sir.
Okay. Was a refraction done to see whether there is any corneal topographic changes or astigmatism or refractive error in the eye which is covered?
Actually, sir, the left eye has complete ptosis and it's very difficult to open the left eye. Also, the child is also irritable when we try to open the eye. This much only can be opened.
Did you do any examination under GA?
Yeah, examination under anesthesia was attempted or not? EUA? Examination under anesthesia?
No, ma'am, we didn't do the examination under GA.
Ideally, we should take the pressure also under GA.
Okay, ma'am.
Okay. Bhagali, madam, anything else from your side?
No.
Okay. Dr. Prachi, please stop sharing your screen.
Okay, ma'am.
Okay.
Our next participant is
Good
Dr.
presentation.
Veena.
Good presentation. Needs a
Thank you.
the patient needs to
Further
be
follow up. Yes.
what we call as till the patient improves, and it's not only the tumor, it is the visual assessment and visual rehabilitation should be planned in the future for this patient.
Okay, sir. Thank you, sir.
Thank you.
Thank you, ma'am.
Okay. Please stop sharing your screen, Prachi.
Yes, ma'am.
Our next participant is Dr. Veena Patil. She's from HV Desai Eye Institute. There are 2 cases for her. First case is about serpiginous-like choroiditis and second one is acute corneal fibrosis. Over to you, Dr. Veena.
Good morning, ma'am. Ma'am, my first case I had taken is acute eye drops. Can I present this as my first case?
Yes, go ahead.
Yeah. Good morning, everyone. It's a delight to be a part of POS and the presentations today. I am Dr. Veena Patil. I'm from HV Desai Hospital. Today, I'm going to present a case on acute eye drops, which is secondary to keratoconus. Okay, we have a 28-year-old female. She's a student, resident of Pune. She came to us with a chief complaint of trauma to the left eye with a metal particle 4 days back, followed by blurring of vision since last 2 days. There was profound worsening in the last 1 day. On examination, the vision in the right eye was 636, pinhole improvement 612, near vision was N12 at 33 centimeter with a refraction of minus 1.5 sphere and minus 2.5 cylinder at 180. Now coming to the distance visual acuity of the left eye.
You go ahead with your
Yeah.
Move the
presentation.
cursor. The next slide. Yeah, it's true. Yeah.
Sir, this part I'm not able to see the left half of my screen.
Here it is visible.
Okay, sir. Yeah.
You go ahead.
Left eye. The left eye distant visual acuity CF 1 meter. Near vision is less than N36. She's not accepting any glass correction. Coming to the slit lamp examination of the right eye, we see Vox Troy in the left eye, in the right eye, and coming to the left eye, there is acute eye drops with cereals positive. We see a video wherein the dye is diluted, fluorescein dye. Now coming to the anterior segment OCT of the left eye, we see corneal edema, superficial. There are bullae that are present, and there are water clefts here. There is a break in the Descemet's membrane. Now, pentacam of the right eye, K1, K2 values are raised, and Kmax is 64. We see the anterior and posterior float, which corresponds to the areas of thin pachy. Whereas coming to the left eye, K1 and K2 are raised. Kmax is 780, which is more sort of the corneal pachy is raised. This says suggestive of corneal edema secondary to eye drops. Now the patient was taken on an emergency base for OT, and she was managed with compression sutures, and C3F8 gas was injected. Now this is the post-op day 1 picture. This is the BCL, and you see that there is a lot, the edema has reduced, water clefts are not seen, and patient has a better vision, and she doesn't have pain, and she is symptomatically better. Now coming to the management algorithm of acute eye drops, the epidemiology, it occurs in 3% of those with KC and 11% of those with other corneal ectatic conditions like PMD and keratoglobus. It is associated with ocular allergies and eye rubbing. Symptoms like our patient had decreased vision, eye pain, or irritation, eye redness, tearing, light sensitivity. Signs are reduced visual acuity, conjunctival injection, corneal edema, signs of underlying corneal ectasia. Management, there are 2 schools of thought. It also depends on the way the patient presents to us. We can go ahead with conservative management, giving cycloplegic drugs and hypertonic saline topical steroid or a BCL, which can do comfort to the patient. Or we can go with the aggressive surgical management if the patient is highly symptomatic, if there is a trivial trauma causing a large Descemet's detachment. So we can go ahead with injection of the anterior chamber with a gas or air, and the last resort is PK or a DALC. Now, so the eyes only see what the mind knows. So a trivial trauma to the patient is actually nothing but acute eye drops in a known case of keratoconus patient. Thank you, ma'am.
Hello.
Yes, ma'am.
Veena, you have not talked anything about the other eye.
Other eye, yes.
Other eye also has keratoconus. So
Yes.
what are you going to do?
Yeah, ma'am, the other eye, the right
that?
eye, yeah, ma'am, we have given her the option of contact lenses, rigid contact lenses. The patient is not very compliant with it. So she is more comfortable with using spectacles. We call her for a regular 3-monthly follow-up to change, to see for any change of refractive error. And there is a, we are planning to do a C3R procedure for her in the coming months, ma'am. She's been advised.
Have you tried any scleral contact lenses? Have you heard about them?
Yes, ma'am. I have heard about scleral contact lenses.
Or scleral contact lenses.
Yes, ma'am. I've heard about them.
Yes.
Yeah. So because of the conical presentation, the scleral or the rigid rose scale lenses, it will indent on the cone, and it will provide the patient will be asymptomatic, and the cone will be taken care of, and the need for C3R or the need for further surgical management, we can just delay it, and we delay the progression of the disease. But the patient is not very compliant. Like I said, she is now comfortable with the glasses, and a regular follow-up has been advised.
No, actually, you have to first treat the condition, do C3R or whatever, and then give scleral contact lenses to give better visual acuity and
Visual
comfort to the patient.
Yes, ma'am.
Okay.
And
Yes.
was the patient in
you.
the past had reported with a was diagnosed case of keratoconus, was on
Yes.
treatment for it?
Yes. She was diagnosed case of keratoconus, sir, both eye.
Okay, so was in past advice for C3R or special contact lenses? Or
Yes,
she
sir.
had
She was advised a C3R procedure in the past, but being a student and she having a very academically a very demanding life, so she then never turned up for a follow up, and she presented with a trivial trauma with a spoon, and then she ended up having acute eye drops in the left eye, unfortunately.
okay.
So actually, you have to do better counseling, telling her that preserving her vision is much more important than doing her studies.
Yeah, sure, ma'am. Yeah.
Thank you so much.
Thank you so much. Thank you, ma'am.
Thank you, ma'am. And good presentation.
Thank you.
Veena, Dr. Veena, you can
Yes.
continue with your second case now.
All right, ma'am. I'll continue. Yeah. So, ma'am, my second case will be a serpiginous like choroiditis. We have a 35-year-old female. She's housewife. She's a resident of Pune. She came to us with the chief complaint of gradual, progressive, painless diminution of vision in the right eye since 2 months. Profound worsening since the last 3 weeks. The vision in the right eye was CF 50 centimeter. Near vision was less than N36. Anterior segment though was within normal limit. Coming to the left eye, vision 6.6, N6, prefers plano. Anterior segment was within normal limit. No history of any trauma or RAPD was noted. Now the dilated fundus evaluation with IDEO was done for her. This is the fundus picture of the right eye, wherein we see grayish yellow ill-defined lesions noted at the superior arcades, both temporal and along the nasal quadrant. Macular involvement is seen, and there is hyperpigmented and hypopigmented areas suggestive of RP atrophy seen at the old scarred lesion inferiorly. So she was clinically diagnosed to be a case of serpiginous like choroiditis. Now an FFA was done. The early phase shows complete filling of the arteries and the capillaries with early lamellar flow in the vein. Dye appears to line the venous wall with axial hypofluorescent strip. Now, mid phase shows lamellar venous flow with heterogeneous areas of hypo and hyperfluorescence. The late venous phase with complete venous filling and reduced arterial fluorescence. Now we see in the late phases that there are active margins, late leakage, and hypofluorescence area is now turned into hyperfluorescence with late phase leakage. There are hyperfluorescence of the disc, hyperfluorescence of the scarred lesion. Coming to investigation, a CBC was done, wherein we see raised WBC and raised ESR counts. Serology was within normal limit, and she was not reactive for HIV or HBsAg. Immunology, her CRP was 10. Chest X-ray, AP and lateral view was within normal limit. Quantiferon TB gold test was positive. MON2 was strongly positive. So we went ahead with the management plan of a conservative line. Patient was started on ATT, isoniazid, rifampicin, ethambutol, and pyrazinamide after taking a pulmonologist opinion and taking her weight into consideration. As we know, ATT kills the microorganism, decreases the antigen load, minimizes the inflammation, and reduces the hypersensitivity reaction, thus eliminates the recurrence of inflammation. Then after 1 week, systemic corticosteroids in the form of oral prednisolone, 1 mg per kg per day was started and tapered slowly. Through 1 week, her vision improved from CF 15 centimeter to CF 2 meter. Eye was quiet, resolving choroiditis was seen. So we see a montage photo of pre-treatment and post-treatment. We see there is a reduction in the activity, flattening and pigmentation and well-defined borders. These are the fundus autofluorescence images. Change in appearance of autofluorescence with improvement in the activity noted. Hyperfluorescence heals to stippled or granular form. Coming to a small discussion on ocular tuberculosis, we know that microbacteria are fungus-like bacteria. They're acid-fast. and they are non-motile, non-capsulated, non-sporing. The essential pathology of tuberculosis is related to the ability of the bacteria to survive and multiply in the macrophages. So they cause a granulomatous reaction. In the old past, it was called the captain of all the men of death. Now we are fighting with ocular tuberculosis, which has a wide spectrum coming with anterior uveitis, anterior, intermediate, and posterior uveitis, wherein we see mutton fat capes, iris nodules, cataract, extensive broad-based posterior synechiae, and in case of intermediate uveitis, we see snow banking, snowball, vascular sheathing, cystoid macular edema, posterior uveitis manifesting as retinal vasculitis, serpiginous like choroiditis, choroidal tubercle, subretinal abscess, and panuveitis. We also have rare manifestations like endophthalmitis, panophthalmitis, and neuroretinitis. Coming to how do we differentiate between serpiginous like choroiditis and serpiginous choroiditis, we have geographical helicoid peripapillary choroidopathy, that is which has a centrifugal spread. This occurs in the healthy patient to 2nd to 7th decade of life with unknown etiology. It is autoimmune, no gender predilection, usually bilateral, chronic, progressive, increased frequency with HLA-B27 and retinal S antigen. Whereas serpiginoid or serpiginous-like choroiditis, it has a centripetal spread. It occurs in an immunocompromised patient, 5th to 7th decade of life. Tuberculosis is the most common underlying etiology in most of the third world countries. Female predilection, unilateral, not associated with HLA-B27 or retinal S antigen. Thank you, ma'am.
Very good presentation, Dr. Veena.
Thank you, sir.
Yeah, I would like to ask here, do you look for any systemic coexisting tuberculosis? Do
Yes,
you do
sir.
other investigations like X-ray chest to find out if there's any coexisting systemic tuberculosis? And is a history of past tuberculosis of any significance in these cases?
Yes, sir. The history of past tuberculosis and history of tuberculosis in any of the family members is very, very important. If the patient is had tuberculosis in the past and due to some reasons like diabetes, or if she's taking any immunosuppressive medication, it could flare up. And there is a need to go have a systemic evaluation to see for any foci of tuberculosis in the spine or maybe in any urinary tract or elsewhere in the body. Not to miss out. Only when we, being an ophthalmologist, we should not just concentrate on the eye, but as a whole, as a physician, we need to just look for other foci of infection as well. She may have a Cole's abscess of the lymph nodes in the neck region. So a thorough clinical evaluation with a pulmonologist and a physician should be done. Also in our OPD at the first visit as well.
Yeah, overall it was a good presentation with
Thank
a
you,
complete workup of the patient and management offered to the patient with a visual recovery, which was appreciated.
Yes, sir.
Overall good presentation. Bhagali
Thank
ma'am,
you, sir.
Yes, very, very good presentation and management, Veena.
Thank
Well
you,
done.
ma'am. Thank you, ma'am.
Yes.
Okay, Dr. Veena, please stop sharing your screen.
Yeah, ma'am.
Okay. Our next participant is Dr. Shivangi Bora. She is from D.Y. Patil Medical College and her topic is sympathetic ophthalmitis. Over to you, Dr. Shivangi. Please unmute yourself and start
Yes,
sharing.
ma'am.
Yeah.
Good morning, everyone. My topic is an eye for an eye. A 42-year-old gentleman residing in Solapur, a carpenter by occupation, presented with diminution of vision in his right eye since 15 days. He also gave history of trauma to left eye 2 months ago. Patient accidentally injured his left eye 2 months ago while hammering a nail into an object which darted into his eye and fell off, after which he developed diminution of vision in his left eye, which was sudden in onset and painful in nature. It was also associated with redness and watering. Following this, the patient went to a local doctor and was prescribed 2 drops. The patient was also advised surgery, which he did not pursue. 2 weeks later, patient presented with diminution of vision in the non-injured right eye, which was sudden, painless, progressive, and also associated with redness and intolerance to light. Patient gave no significant past history or history of any systemic diseases. Patient was using 2 drops, details of which was not known, in the injured eye, which was started at the local hospital in his hometown. On general physical examination and systemic examination, patient was within normal limit. On ocular examination, in the right eye, the visual acuity was reduced to finger counting at 1 feet. Projection of rays was accurate in all 4 quadrants. In the left eye, the vision was reduced to perception of light, projection of rays being inaccurate superiorly and inferiorly. Near vision could not be assessed. Extraocular movements were full, free, and painless in all gazes. Ocular adnexa and orbit were within normal limit. Intraocular pressure in the right eye was 10 mm of Hg, and in the left eye, it was 20 mm Hg. On slit lamp examination of the anterior segment of the left eye or the injured eye, it revealed circumcorneal congestion. There was a sclerolimbal wound. A sclerolimbal wound was present, which was unsutured and self-sealed. The linear wound extended 4 mm over the cornea with uveal incarceration. There was deep vascularization, especially at the site of endothelial lenticular touch. AC was flat temporally, owing to the anteriorly subluxated lens. Iridodialysis was also noted from 1 to 4 o'clock, and there was also neovascularization of the iris. Pupil was irregular and not reacting to light. Iris pigments were present all over the lens with posterior synechiae, and the lens appeared cataractous. Fundus could not be visualized because owing to the cataractous lens. B-scan of the left eye or the injured eye showed moderately echogenic opacities in the vitreous cavity not attached to the retina, suggestive of vitreous hemorrhage with chorioretinal thickening. On anterior segment examination of the right eye or the non-injured eye, there was mild circumcorneal congestion with mutton fat keratic precipitates in the Al's triangle. The anterior chamber revealed reaction of 3+ cells with flare and formation of posterior synechiae, which led to a festooned pupil. Fundus could not be evaluated properly due to media being very hazy. The B-scan revealed vitreous cavity showing multiple high echogenic opacities, which was suggestive of vitreous exudates with retinal detachment. The diagnosis is sympathetic ophthalmia with left eye or the injured eye as the exciting eye and the right eye or the non-injured eye as the sympathizing eye. The patient was immediately started on systemic corticosteroids, topical antibiotics, topical cycloplegics, and a subtenence injection of dexamethasone 2 mg was given in the non-injured eye. After 2 weeks of treatment, patient showed significant improvement in the sympathizing eye or the non-injured eye, with distant vision improving to 624 parts and near vision to n/12. There was resolution of the ocular inflammatory signs. Festoon pupil was still present due to the presence of posterior synechiae. On fundus examination, media was clear with normal posterior pole and resolution of the exudative RD. Plan of management for the left eye was cataract extraction with lens implantation after the control of inflammation. B-scan was repeated before discharge, which showed right eye with only the presence of chorioretinal thickening, and in the left eye, there was presence of vitreous hemorrhage with chorioretinal thickening. Coming to discussion, sympathetic ophthalmia is a rare bilateral granulomatous panuveitis following accidental or surgical trauma to one eye. Clinical presentation is most often within days to years after trauma. Anteriorly, it manifests as chronic or acute uveitis. Posteriorly, it is often accompanied by Dallen-Fuchs nodules, optic nerve swelling, and exudative RD. Differential diagnosis includes other causes of granulomatous uveitis such as VKH disease, sarcoidosis, tuberculosis, syphilis. The diagnosis...
Last 1 minute remaining, Shivangi.
Yes, ma'am. The diagnosis is made clinically with a history of penetrating trauma or prior surgery in the recent past, which has been treated insufficiently. An association with HLA-DR4 has also been seen. Corticosteroids remain the mainstay of treatment. visual prognosis is reasonably good with prompt appropriate wound repair and medical management. Take-home message is prompt detection and treatment is of utmost importance in this bilaterally blinding disease. A possibility of sympathetic ophthalmia must be kept in mind while treating trauma and post-surgical patients. And with the advent of newer treatments, easier access to eye care and heightened awareness, there is improved prognosis. These are my references. Thank you.
Please switch on your video also, Shivangi.
Oh, okay, ma'am.
Good presentation.
Thank
Because
you,
generally nowadays, sympathetic ophthalmia is now very rare to see a case.
Yes, sir.
Just wanted to ask what type of systemic steroids were given at your center in the first instance?
Yes, sir. So we started with IV methylprednisolone at a dose of we started at a dose of 1 mg, 1 gram per day, sir.
For how many days?
So we gave it 1 gram per day for 3 days. Then we tapered to oral corticosteroids, which we gave, sir, 1 to 2 mg per kg per day. And we slowly...
Was it given along with intravitreal steroids also, or it was only systemic steroids was given in the initial?
No, sir. Only 1 injection of dexamethasone was given, sir, in the injured eye at the time of presentation. After that, we started IV drugs, and then we tapered it to oral corticosteroids, which was later tapered.
Okay.
Yes, sir.
Bhagali ma'am, your comments, ma'am, please.
Madam, please unmute yourself.
I thought you had given the subconjunctival injection of dexamethasone in the non-injured eye.
Yes, ma'am, in the non-injured eye only.
Yes, and the injured eye
Injured
had...
No, ma'am. In the injured eye, we did not give any injection. Like we did not give subconjunctival because, ma'am, the eye was already very. The lens was also subluxated anteriorly, and it actually already had very poor prognosis because the patient did not come for 2 months, and we were already giving systemic corticosteroids in the form of IV drugs. The other eye was showing signs of improvement, so we gave an injection in that eye, ma'am.
Okay, and what was the vision post-op after you are doing a lens implant?
Ma'am, we haven't done that, ma'am. That was a plan of action, but the patient has not followed up since then. At that time, there was a lot of inflammatory reaction. That's why we had not done anything at that time. But later on, we had planned that after there is resolution of inflammatory signs, we will plan for lens extraction because there was no improvement in vision in that eye, ma'am.
Yes, because usually when there is no visual prognosis, nobody is going to put an IOL.
Yes, ma'am. We were not going to put. We were planning on just removing the mainly removing the cataract.
It is just cleanup job that you have to do.
Yes, ma'am.
It is better if you do the surgery and separate the synechia and create good planes. That is most important, because if the uvea is incarcerated in the corneal wound, then the inflammation is not going to resolve
on its own. Yes, ma'am. Yes, ma'am. Yes,
in past, people used to enucleate the eye because, just to save the normal eye.
Yes, ma'am. Okay, ma'am. Yes, ma'am.
What I was saying that what my impression was that intravitreal as well as subconjunctival steroids were given into the injured eye, which is more important. Surgical intervention is required not only for clearing the cataractous lens, but as ma'am rightly pointed out, it's a uvea which is the inciting factor. You have to get the planes made, remove the iridocorneal or scleral and uveal incarceration. Synechia has to be removed.
Yes.
So surgical intervention has to be planned at the earliest, not at the later date.
So actually, after the injury, the patient did not come for 2 months to our hospital. He came after 2 months, after the other eye was already involved since 2 weeks. That's why we did not consider enucleation at that point.
You must have admitted the patient since you are giving the intravitreal.
Yes, sir. We admitted the patient after that. Yes, sir.
You had the patient in your control so that you could have better counseled and planned for definitive surgical intervention in this case. Because
you have to do the surgery. Yeah, sorry. Yeah, go ahead.
Yes, other eye is more important in such cases.
Yes, sir.
Okay. Our next participant is Dr. Varsha Singh. She's from D.Y. Patil Medical College, and she's going to talk about congenital glaucoma. Over to you, Dr. Varsha. Please start sharing the screen and switch on your audio and video both. Dr. Varsha Singh.
Yes, ma'am. Good morning. I will be presenting on the topic, the silent thief of sight, congenital glaucoma. The case is of an 11-year-old male child from a family of farmers. The informant was grandfather and reliability was poor. The patient came with complaints of diminution of vision and bluish discoloration with globe enlargement of both eyes since last 5 years, which was gradually progressive and painless in nature. The patient had undergone glaucoma surgery in left eye 1 year ago at Ahmednagar, and there was no history of spectacle use and ocular trauma. There was no significant birth history. The patient was born out of a non-consanguineous marriage and was studying in 3rd standard, immunized till date, and there was no history of blindness in family. The patient had history of putting anti-glaucoma eye drops in left eye since 1 year post-surgery. The general physical examination was within normal limits. There was no association of other systemic or ocular abnormalities in the patient, and systemic examination was also within normal limits. Coming to ocular examination, as we see here, that the vision in both eye, right eye and left eye, is reduced to 660, which was not improving. On a retinoscopy, we find that both the eyes are highly myopic with astigmatism, and other ocular examination was within normal limits. Coming to anterior segment examination, as we can see here in this picture, that that descending membrane folds are seen in the right. The descending membrane folds are seen in both eyes on slit lamp examination with megalocornea. And in the picture down here, we see the HAB striae, which is more visible on retroillumination and full pupillary dilatation. Coming to fundus examination, as we see here, the normal fundus picture with the normal cup to disc ratio should be 0.3. And when we compare it to glaucomatous fundus picture, we see in the right eye that the CD ratio is increased and occupying the entire disc area, which is almost 0.9 in right eye with all quadrants of NRR thinning. And also in the left eye, we see the increased cup disc ratio to almost 0.7 with superior and inferior NRR thinning. The investigation that was done for this patient was the corneal diameters, as I mentioned earlier, that megalocornea was present, which is almost 14 into 14 mm in both the eyes. On gonioscopy, the angles were found to be open and central corneal thickness in both eyes were reduced. The axial length was also found to be increased in both eyes due to enlargement of the globe, and the corrected intraocular pressure taken on Goldman's applanation tonometry was found to be increased in both eyes, right eye more than left eye. A diagnosis of congenital glaucoma, both eyes was made, and plan of action was surgical management. Before seeing what we had done for this patient, let's have a look at the surgical options available. Firstly, first thing that we can do for such patients is goniotomy, which is we take a goniotomy and we make a superficial incision at the uveal meshwork, but this can only be done if the cornea is clear, which was not in this case. Second procedure that can be done is that from the external approach, we open the sclera, and this instrument that can be seen in this picture, that is the Ham's trabeculotome, which can be inserted into the sclera, thus breaking the trabecular meshwork and rotating into the anterior chamber to drain out the aqueous. The third procedure that can be done is the scleral flap is taken and a pathway is created for, like in this picture, if we can see that a pathway is created for the aqueous to drain out, thus lowering the IOP, and that is the main aim of this procedure. And fourth procedure that can be done is tube shunt implantation. Here we see the glaucoma drainage devices that can be implanted, and the tube is implanted into the anterior chamber, which drains out the aqueous. Now, the treatment which was done for my patient was the patient underwent combined trabeculotomy with trabeculectomy with mitomycin C application under general anesthesia, first right eye followed by left eye 2 months later. On follow-up, the patient vision was improved to 6/36 in both eyes, and patient was given spectacle correction for the myopia. And IOP was taken, which was again increased in right eye, which was 28, but then it was decreased from the initial assessment, and that is why patient was started on hydrooptimanol, which is of beta blocker class anti-glaucoma medication. Coming to congenital glaucoma, it is classified as primary congenital glaucoma, which is primarily due to the anterior chamber malformation, and secondary glaucoma, which is associated with other ocular or systemic conditions. The pathophysiology that is involved in this is the maldevelopment of the angle structures, which lead to impaired aqueous outflow and thus leading to increased IOP. The clinical features, as you can see here, as you can see in this eye here, when we compare with the right eye, there is increased globe size, which is called as a biphthalmos, and the size of the cornea is also increased.
Dr. Varsha, last 1 minute, kindly conclude fast.
Yes, ma'am. And the other features are Habstri and stromal haze seen in this year because of increased IOP. The diagnosis is examination and anesthesia should be made. IOP measurement should be taken. Anterior chamber examination with fundus examination should be taken, along with the gonioscopy should be done. My take-home message is that every child with epiphora and photophobia must be screened for glaucoma, and early treatment of glaucoma leads to better outcome. And big blue eyes are usually perceived as pretty eyes by the parents, so they tend to not take their children to the hospital, but they are supposed to be warning sign for us. These are my references. Thank you.
Any questions, ma'am? Meenakshi ma'am? Nitin sir?
Any of the siblings were screened for glaucoma? Varsha?
Yes, ma'am.
Did you screen his siblings for glaucoma?
Ma'am, he was a single child of his parents, ma'am.
No, siblings of other cousins.
Other cousins.
No, ma'am. For the cousins, it was not done, ma'am.
Okay.
Okay. Overall, good presentation. Requires very surgery is very difficult to master if they have done the trap plus trap, because nowadays we don't see the cases on a very regular basis, at least in our center, to have a congenital glaucoma which needs a surgical intervention. So sometimes we find those people are have a difficulty to get the trabeculotome, Ham's trabeculotome we also have, but to get into the plane is difficult many times.
Yes.
Thank you.
Well managed case, Varsha. Yes, thank you.
Ma'am, thank you.
Thank you, Varsha.
Varsha, please stop sharing your screen. Our next participant is Dr. Yogita Gote. She's from Dinanath Mangeshkar Hospital, and she's going to talk upon the topic of recent advances to salvage the globe in case of retinoblastoma. Dr. Yogita, please unmute yourself and switch on your video. Start sharing the screen. Dr. Yogita?
Yes, ma'am, sharing the screen.
Okay.
Good morning, everyone. My topic is recent advances in management of retinoblastoma to salvage the globe. So I will start with my case. A 7-month-old male child brought by parents to IOPD with complaint of white ring-like reflex and inward deviation of right eye noticed by his parents 15 days back while clicking photographs. The child was full-term and normally delivered. There is no history of NICU stay and the baby was immunized till date. There is no similar presentation in siblings and parents. There is no consanguineous marriage. On ophthalmic examination, the head posture and facial symmetry was well maintained. And there is right esotropia on Hirschberg test, and extraocular movements were full and free in both eyes. On the visual acuity in both the eyes, the child can follow light and objects, and the anterior segment in both the eyes was within normal limit. On dilated fundus examination, the right eye media was clear, and there is a large whitish globular mass about 10 by 9 disc diameter covering entire macula with central calcification supernasal to disc. The mass is encroaching towards the disc, and there is vitreous shadings present. In the left eye, the media was clear and this was of normal size, but there is small 1.5 mm mass peripapillary inferior to disc and no vitreous shadings present. The child.
Dr. Yogita, your slides are not advancing. Please start the slideshow and just move the slides manually. You can just see the beginner slide only. Just move your slides. Or you just start the slideshow.
Slides, but it is not visible.
You just
Okay.
click on the slide.
If the slide, okay, Dr. Yogita, if the slideshow is not working, you just show the next slide as you speak.
Yes.
Okay, sir. Is it visible, ma'am? Next slide.
No.
No.
Presently, your first slide is only visible. Only first slide is visible. You show the second, third slide, and then show as the slides you advance.
Is it visible, ma'am?
Yeah, but advance the slides.
Just click on the slide and click on the slideshow also. You can click.
Is it okay, ma'am?
Go to the slideshow mode. Can't you click on that slideshow which is there in the toolbar?
Clicked. I have clicked on that, ma'am.
Okay, Dr. Yogita, if the slideshow is not working, you show the slides in the present format only. Show the next slides as you speak.
Yeah. Okay, go ahead. Start. Just click on the slide and talk.
Okay.
Right.
Yeah.
Yeah, Dr. Yogita. Just start.
On dilated fundus examination, in the right eye, the media was clear, and there is large whitish globular mass about 10 by 9 disc diameter, covering entire macula with central calcifications in supernasal to disc. Vitreous shadings was present, and in left eye, the media was clear, and there is small 1.5 mm mass peripapillary inferior to disc, and there is no vitreous shadings. Child underwent the investigations like USG B scan, MRI orbit with brain screening with CT correlation under anesthesia, and red cam imaging. During her MRI orbit with brain screening, we did the examination under anesthesia. And on the MRI, there is, as we can see in the T2 weighted MRI of right eye, there is a hypointense lesion along posterolateral wall, measuring about 1.7 by 1.2 by 1.1 centimeter. And on CT correlation, there is multiple tiny calcification clustered within the lesion. On USG B scan, there is large globular mass noted along posterolateral wall with few reflective specks. The red cam imaging was done for documentation and monitoring the effect of treatment. In the right eye, there is large globular mass with retinal vessels over the mass, and in the left eye, the MRI image is not showing any mass lesion in the left eye, as it is very small. So, but on clinical evaluation and RETCAM imaging, we are able to see a small lesion 1.5 mm in size, inferior to the disc. So my diagnosis from the clinical imaging findings is right eye is group C retinoblastoma, and in left eye there is group B retinoblastoma. My differential diagnosis are congenital cataract, but here the lens is clear, persistent hyperplastic primary vitreous, toxocariasis, and stage 5 ROP. Tumors like astrocytic hematoma, medulloepithelioma. The patient is then referred to the pediatric oncologist for further investigations like CSF analysis.
Last 1 minute.
Bone marrow biopsy to look for any metastasis, as it is bilateral and so we started with the systemic chemotherapy and standard regimen like vincristine, etoposide, and carboplatin was started. After 2 cycles, we will give him transpupillary thermotherapy, and if required, we will think of intraarterial chemotherapy. In this case, we can give melphalan, topotecan, and carboplatin. So, thank you.
Okay. Questions from judges for Dr. Yogita?
Bhagali ma'am, your comments, please, ma'am.
Ma'am, please unmute yourself first. Meenakshi ma'am, please unmute yourself. Bhagali ma'am, you are not audible.
I'm not audible yet?
Yes, now you can.
Again, you are not audible. Right.
Okay. So, what was the outcome after giving all these treatments?
Actually, ma'am, he is under treatment. Only first systemic chemotherapy we had given, and after 2 chemotherapy, we will do his ophthalmic evaluation for any regression, and we'll give transpupillary thermotherapy.
Okay. So you don't know the follow-up as it is?
No.
And what side effects are you looking for in a child?
Ma'am, there is some disturbance in the audio.
Okay, go ahead. Yeah.
Ma'am, please repeat the question.
Yeah. Are you doing any parameter study effects of the... Okay, it's okay.
Vichare sir, any questions?
Dr. Yogita, any idea about intraarterial chemotherapy or any options available at your center for intraarterial chemotherapy?
Sir, in this patient, we are given him intraarterial chemotherapy option. But for this case, we are trying to give intravenous and then thermotherapy only.
Okay.
And in intraarterial, we can give through femoral artery mainly.
No, the end artery, it's not through femoral, but end artery. Have you consulted the NOK as well as parents about the possible requirement of enucleation in such cases?
Yes, sir. All the options regarding the treatment we had explained to the parents. Initial 3 options, that is systemic chemo, thermotherapy, and intraarterial we had given. In worst case, we may land up if there is no regression.
Okay. Dr. Bhagali, ma'am.
Yes, and since your patient is still under treatment, we don't know if he is going to show any side effects.
Yes.
Yes, ma'am.
Again, in this case, I wanted to ask,
are you monitoring any liver functions or anything?
Yes, ma'am. We are monitoring liver function, renal function. There is after first cycle, there are nothing abnormalities in that.
Okay. Okay, that's good.
As with the previous case by presented, have you screened other siblings as well as parents for the possible healed or possible retinoblastoma?
No, sir. But after settling this issue of this child, we will screen the parents and siblings.
Okay.
Okay.
Thank you. Thank you.
Thank you. Thank you.
Now move ahead to our last participant. She is Dr. Adya Bagchi from Dinanath Mangeshkar Hospital, and she is going to talk about the management of ocular cicatricial pemphigoid. Dr. Adya, please unmute and start sharing the screen. She's our last participant for today. Over to you, Dr. Adya.
Yes, ma'am. Ma'am, is my screen visible?
Yes, yes.
Yeah. Good morning, everybody. I'm Dr. Adya, second year ophthalmology resident at Dinanath Hospital, and I'll be speaking about multidisciplinary approach for the management of ocular cicatricial pemphigoid. My patient is a 71-year-old female housewife by profession, resident of Pune, and she came to our IOPD with complaint of diminution of vision, along with redness and pricking sensation in both the eyes since last 2 years. All these complaints was associated with photophobia, watering, foreign body sensation in both the eyes, and she had mild pain and discharge in the right eye since last 15 days. Systemic history, she does not have any known systemic comorbidities, though the patient is a known case of CA stomach. She was treated with chemotherapy, radiotherapy, and surgical resection in 2010, but the details are not very clear. On ocular history, she underwent left eye cataract surgery in 2018. She does not give any history of spectacle use since childhood, no history of any recent trauma or any past trauma to the eye, no history of use of any topical medications for both the eyes in past. On ophthalmic evaluation, her visual acuity in the right eye is counting fingers till 2 meters, near vision is less than 36, left eye is counting fingers till 1 meters and less than 36. Head posture, facial symmetry were within normal limits. Coming to the adnexal evaluation, I'll go with the right eye first and then we'll continue with the left eye. Right eye lids, there were mildly edematous margins with skin excoriation. Conjunctival congestion could be seen with mucopurulent discharge. Upper and lower fornicial shortening was seen, and early symblepharon formation could be seen in the inferior fornix. The cornea in right eye showed diffuse nebular epithelial haze with 360-degree vascularized pannus, and there was diffuse epithelial stippling. Anterior segment iris were found to be normal. Pupil were normal size, normally reacting to light. The patient had grade 3 nuclear sclerosis with a dense posterior subcapsular cataract. IOP was found to be 16 millimeters of mercury by Goldman's applanation. And because of the cataractus lens, her dilated fundus examination had a very hazy and difficult view. Coming to the findings of the left eye, the lids were mildly edematous lids had mildly edematous margins with skin excoriation. Conjunctiva had mild congestion with upper and lower fornicial shortening, and early symblepharon formation could be seen inferiorly. The left eye cornea showed a diffuse nebular epithelial haze with 360-degree vascularized pannus. There was a corneal scar 3 mm into 3 mm with irregular boundaries extending from 9 o'clock position to 11 o'clock position, and this eye also had a diffuse epithelial stippling. Anterior segment and iris were found to be normal. The pupil were normal size, normally reacting. Left eye, she had a PCIOL. IOP was around 16 to 18 millimeters of mercury by Goldman's applanation tonometry. The fundus, because of the cornea, had a hazy view, but dilated. The posterior segment was found to be within normal limits. The Schirmer test for right eye showed 12 seconds. For the left eye, it showed 10 seconds. And both the eyes, the patient had almost stenosed punctum. These are the photographs which show conjunctival congestion with foreshortening of the upper and the lower fornices in both the eyes. And as you can see in the left eye, there was an old corneal scar with irregular borders extending from the 9 o'clock position to 11 o'clock position in the superotemporal quadrant. My provisional diagnosis for this case is ocular cicatricial pemphigoid or mucous membrane pemphigoid. My differentials are Stevens-Johnson syndrome, but the examination did not show any keratinization. Limbal stem cell deficiency also also has a similar picture with a 360-degree pannus formation, but the conjunctival congestion and fornicial findings go against it. Paraneoplastic pemphigus can also be a possibility, but because of the clinical findings. But paraneoplastic pemphigus is more commonly seen in lymphoid carcinomas. Atopic keratoconjunctivitis and is ruled out because there is no seasonal or diurnal variation with the signs, and the patient does not give any she does not tell anything which causes increase in the symptoms. And pseudopemphigoid can be ruled out because she did not give any history of previous topical medications. Management, the patient was advised systemic management, hemogram, urine protein, renal function and liver function tests were advised. For ophthalmic, conjunctival biopsy was done, and the patient at the same time was started on topical medications.
Last 1 minute, Dr. Adya. Please continue.
Topical tacrolimus ointment was given, eye drop, cyclosporin, steroid plus antibiotic eye drop, and lubricants were given. Surgical conjunctival biopsy was performed from the inflamed area, which showed subepidermal bulla along with the underlying mixed inflammatory infiltrates. On immunofluorescence, we could see linear IJ deposition along the basement membrane. Follow-up after 1 week with reports showed resolving right eye complaints, but due to slow healing of the left eye, amniotic membrane grafting was done for the left eye. These are the photographs from the surgery. And systemic immunomodulation with cyclophosphamide and folitrate was started for her. And follow-up after 1 week showed good eye opening in both the eyes. Left eye BCL was intact with disintegrating AMG. Patient was seen comfortable for the first time in many days. And I have a few photographs after 1 month which showed resolution of the conjunctival complaints and healing corneal epitheliopathy. These are my references. Thank you.
Questions from judges?
Yeah, one question. Very good presentation. How long do you continue systemic immunosuppressants?
Sir, the systemic medications have been started, and mostly we have to give. The systemic medications are given for 1 month, and then follow-up is done about the resolution. But at least for 6 months, the treatment should be given, and then there should be a slow tapering of the medications. And it is decided according, and if the medication has to be switched, and those things depends upon the lab and the subsequent findings. Like the patient could have been started on Dapsone also, because Dapsone has proved to be good for treatment of IgA, but because it causes hemolysis and the patient was not recovering required because of the severity of the disease, the patient was started on cyclophosphamide.
Good presentation.
Good presentation overall.
Thank you, sir.
Very well managed. How long do you plan to continue your local immunosuppression, like cyclomune you have started?
Ma'am, like now she's taking it on a daily basis, but if there is resolution of the symptoms, then a slow tapering of the topical should be done of the cyclosporin.
No, usually we start cyclosporin for BD doses, and you can't taper it. You have to.
It's a long-term treatment.
Yeah, long-term treatment. Yes.
Okay. Okay.
Was evaluation from the rheumatologist was done?
Sir, she was sent to an immunologist, and the immunologist only started after her investigation. She was started on cyclophosphamide.
Okay.
Yes.
Good. Well managed case. Very nice.
Thank you, ma'am.
Thank
Thank you, ma'am.
Thank you.
Thank you.
Nitika?
Yes, sir. Now, I would like to call upon Dr. Sanjay Shah, sir, our chairperson, to kindly sum up the session. Sanjay, sir.
Hello. Yeah, it was wonderful case presentation by all the presenters. And it was nice to see a variety of cases with lots of learning to all of us. And hope to see similar presentations in future. Thank you.
Dr. Seema ma'am will give a vote of thanks now. Our own treasurer, Dr. Seema Khere.
Good morning, all. Thank you for this wonderful clinical meeting. I thank Chairperson Dr. Sanjay Tekawade, Dr. Colonel Dr. Shashi Parabha. I thank judges of Dr. Meenakshi Bhagali Madam, Dr. Colonel Vichare, and I thank Dr. Sanjay Shah sir for his valuable inputs. I thank Moderator Dr. Nitika Tripathi, and I thank Dr. Vivika for arranging this wonderful clinical meeting. Thank you all, wonderful audience, and thank you DGC for their support. Thank you, one and all. And
Thank you. Thank you very much.
Thank you, everybody. Thanks for the.
I would request all of you to switch on the videos so that we can have a screenshot. Mr. Piyush, could you just take a screenshot of the participants, please?
Sure.